Okay, thank you very much. Buenas tardes. Before I forget, I do want to tell you that I had lunch with Dr. Souza, and I thought she had a brilliant insight. You remember this morning people were asking about why PPIs might work for patients with nutcracker esophagus, even though there's no esophagitis. We always assumed that the PPIs were just cooling the inflammation from the esophagitis. But if you recall, Dr. Souza pointed out that the PPIs can interfere with cytokine production by the esophagus, and some of those cytokines that they produce have very profound effects on esophageal motility. And perhaps that's the effect that we're seeing. Maybe it's not related to reflux disease as we've always assumed. All right, let's move on to Barrett's esophagus. The American Gastroenterological Association has defined Barrett's esophagus conceptually as the condition in which any extent of metaplastic columnar epithelium that predisposes to cancer development replaces the stratified squamous epithelium that normally lines the distal esophagus. Now, a biopsy of the esophagus at this level shows you the junction between normal esophageal squamous epithelium and intestinal metaplasia. And we recognize immediately that this is intestinal metaplasia because it has these very prominent and distinctive goblet cells. But what if we took a biopsy at this level, and instead of finding this junction between squamous epithelium and intestinal metaplasia, instead we find this junction between squamous epithelium and a columnar mucosa that has no goblet cells? So what is this condition? This columnar lining, which is made up exclusively of mucus-secreting cells, is called cardiac mucosa. We called it cardiac mucosa because traditionally we assumed that this is the lining of the normal gastric cardia. And in the United States, if this were the only columnar epithelium that we found in our patient's esophagus, we would not make a diagnosis of Barrett's esophagus. But in 2005, the British Society of Gastroenterology defined Barrett's esophagus as one in which any portion of the normal squamous lining has been replaced by a metaplastic columnar epithelium which is visible macroscopically. And metaplastic columnar epithelium includes that cardiac mucosa that I just showed you. So a British gastroenterologist would tell this patient with cardiac epithelium in the esophagus that he has Barrett's esophagus, while an American gastroenterologist would not. Now, I could easily spend the next hour talking about cardiac mucosa, but I would bore everyone in the audience to tears, and I don't want to do that. So let me summarize this complicated issue for you very briefly. First, it is clear that in some, if not all cases, cardiac mucosa is a metaplastic lining, meaning that it is acquired as a result of chronic reflux disease. Cardiac mucosa expresses molecular markers of intestinal differentiation, like vilin and CDX2. And cardiac mucosa exhibits DNA content abnormalities very similar to those found in the intestinal metaplasia of Barrett's esophagus. So this really is a kind of intestinal metaplasia, even though it doesn't have goblet cells. Cardiac mucosa frequently is found next to esophageal adenocarcinomas. And at least one study suggests that the cancer risk for cardiac mucosa is similar to that for intestinal metaplasia. So these data all would support the British contention that cardiac mucosa qualifies for a diagnosis of Barrett's esophagus. But regarding this intestinal metaplasia with goblet cells, remember that our estimates of cancer risk in Barrett's esophagus are based largely on studies that included patients with intestinal metaplasia, either primarily or exclusively. And even though the goblet cell itself is a highly differentiated cell that seems very unlikely to be the cell of origin for a cancer, nevertheless, the goblet cell does seem to be a very good marker for malignant predisposition in the esophagus. And even though there are contradictory data, most studies on this issue suggest that the cancer risk for patients who have cardiac mucosa alone in the esophagus really is minimal. So for all these reasons, the AGA decided to separate its conceptual definition of Barrett's esophagus from its diagnostic criteria. Conceptually, Barrett's is the condition in which metaplastic columnar epithelium that predisposes to cancer development replaces the stratified squamous epithelium that normally lines the esophagus. And since for now, intestinal metaplasia with goblet cells is the only mucosa that clearly predisposes to cancer, then intestinal metaplasia remains a diagnostic criterion. Now, if future studies confirm that cardiac mucosa really has a malignant predisposition, then our conceptual definition will not have to change, but we might change our diagnostic criteria. This distinction between a conceptual definition of a disease and its diagnostic criteria might seem trivial, but I think it makes sense because future refinements in our endoscopic or histological techniques, like Dr. Souza just discussed, those might alter our diagnostic criteria, but they won't alter the concept that Barrett's esophagus is a medical condition only because it predisposes to cancer. And this is the cancer that Barrett's predisposes to. Now, Barrett's is the result of metaplasia. Again, this is the process in which one adult cell type replaces another adult cell type. Metaplasias occur in many organs, like in the lungs or the uterine cervix. And usually when a metaplasia occurs, it's because there has been some kind of chronic inflammation. In the esophagus, the stratified squamous epithelium that normally lines the organ in the setting of GERD and the chronic inflammation of reflux esophagitis is replaced by an intestinal type epithelium called specialized intestinal metaplasia. Now, we have many unanswered questions regarding the pathogenesis of Barrett's metaplasia. You might recognize this slide, which I stole from Dr. Souza. She told you about this earlier this morning, but we'll discuss it just briefly now. There's general consensus that the process starts with the reflux of acid and bile from the stomach into the esophagus, and this damages the squamous mucosa. Ordinarily, mucosal damage is repaired by the regeneration of more cells of the type that were injured, in this case, squamous cells. But in the setting of chronic reflux, sometimes this doesn't happen, and instead the esophagus repairs itself through columnar metaplasia, replacing squamous cells with columnar cells. Now, we don't know why this happens, but we have a number of theories. Barrett's could result from transdifferentiation, in which mature squamous cells change into columnar cells, or more likely through transcommitment, in which progenitor cells in the esophagus that normally would differentiate into squamous cells instead differentiate into columnar cells. Now, presumably, either one of these processes, transdifferentiation or transcommitment, would occur because reflux induces alterations in the expression of some of the key developmental transcription factors. You heard about this recent research in animal models suggesting that Barrett's might result from the upward migration of stem cells from the gastric cardia or from the expansion of a nest of residual embryonic cells that's located at the gastroesophageal junction. And in both of these hypotheses, columnar progenitor cells located at or near the GE junction migrate upwards to repair the damaged esophagus by differentiating into columnar cells. And finally, in the rat model of reflux esophagitis, Barrett's appears to occur when circulating stem cells from the bone marrow get transported through the blood to the damaged tissue where they differentiate into columnar cells. So these are our hypotheses. It's not clear if any of them are correct. Now, we worry about Barrett's esophagus because its incidence has been rising so dramatically. It has risen from 3.6 per million in 1973 to 25.6 per million in 2006. That's more than a 7-fold increase over the course of only 3 decades. So this tumor, its incidence clearly has been rising. But it's ironic that at the same time that our estimates of cancer risk for individual patients with non-dysplastic Barrett's esophagus have been getting lower. In the 1990s, we thought that 1 in every 100 patients with Barrett's developed cancer each year. In the year 2000, we learned that that was an exaggerated estimate. It was based on reports suffering from publication bias. And look at the results of some large studies on non-dysplastic Barrett's that have been published over the last 2 years. Here's a meta-analysis of more than 11,000 patients followed for more than 58,000 patient years, and here they found a cancer incidence of only 0.33% per year. A multi-center US study, more than 6,000 patient years of follow-up, annual cancer incidence, 0.27%. A much larger population-based study from Northern Ireland also found a cancer incidence of 0.27. And the largest population-based study to date followed Danish patients who had Barrett's with intestinal metaplasia for more than 56,000 person years, and the overall cancer incidence was only 0.12%. So it seems about every 10 years or so, we downsize our cancer estimate by about 50%. And so in the year 2013, it appears that 1 in every 400 patients with non-dysplastic Barrett's esophagus develops a cancer every year. Now, these recent lower estimates of cancer risk for non-dysplastic Barrett's do raise some very serious questions regarding the value of endoscopic surveillance and of interventional therapies like ablation that we will discuss. But these questions pertain to non-dysplastic Barrett's esophagus. If you have high-grade dysplasia in Barrett's, then cancer develops at the rate of about 6% per year, and most experts agree that that is a risk that warrants some kind of intervention. And we used to spend a lot of times at meetings like this discussing what the intervention ought to be. Until recently, we had 4 valid management options for Barrett's patients. You could do endoscopic surveillance every 3 months and wait until you see a cancer develop to actually do something invasive. You could destroy the dysplasia with ablation. You could resect the dysplasia with this technique of endoscopic mucosal resection, or you could remove the esophagus surgically. And again, we used to spend a lot of time on debates regarding which is the best. But the AGA recently made it easy for us by saying that we recommend endoscopic eradication therapy rather than surveillance for the treatment of patients with confirmed high-grade dysplasia in Barrett's esophagus. So let's now discuss endoscopic eradication therapy. But first, you have to consider the histology of the esophagus to make meaningful decisions about this. Now remember that the muscularis mucosae is the thin muscle layer that separates the mucosa from the submucosa. And you can further subdivide the mucosa by the basement membrane. The epithelium sits on top of the basement membrane, and the lamina propria is a layer of connective tissue that sits under the epithelium but on top of the muscularis mucosae. T1 tumors involve the mucosa and submucosa. T2s involve the muscularis propria. T3s penetrate the muscularis and involve the adventitia. And T4s invade adjacent organs. Now, this is the classic T staging of esophageal cancer. But I want to make the point that none of the lesions that I show you on this slide are appropriate for endoscopic therapy, because endoscopic therapy is only for tumors that are limited to the mucosa. And even the T1 lesion, shown on this slide, extends into the submucosa, where its metastatic potential is very high. Now, we might cure this neoplasm. That's what we call high-grade dysplasia. It involves only the epithelium. It doesn't break through the basement membrane. And endoscopically, we might cure this tumor. This one has broken through the basement membrane. It involves the lamina propria, but it doesn't reach the submucosa. And that's what we call intramucosal carcinoma, or a T1A lesion. These are the lesions that we can cure with the endoscope. But we don't attempt to cure this T1B tumor endoscopically because it has penetrated into the submucosa, and lymph node metastases are found in more than 10% of T1B tumors. And before we leave this cartoon, I want to point out one more important feature, because unlike the colon, the esophagus has lymphatics that regularly extend all the way up into the mucosa. And so even a mucosal neoplasm, in theory, has the potential to metastasize to regional lymph nodes. Now, how often does that happen? How often do these mucosal tumors metastasize? Well, one of Dr. Souza and I's colleagues, Carrie Dunbar, recently reviewed this literature. And she looked specifically to review the risk of lymph node metastases for high-grade dysplasia or intramucosal cancer in Barrett's esophagus. She looked for studies that included patients who had the esophagus taken out. They had it removed surgically because they had high-grade dysplasia or intramucosal carcinoma. And then they had final surgical pathology reports, including the lymph node status. There were 70 relevant articles, including more than 1,800 patients. And the bottom line is that lymph node metastases were found in only 26 for a frequency of 1.39%. So it's very uncommon for these mucosal neoplasms to metastasize. But it appears that the risk of lymph node metastases for mucosal neoplasm is in the range of 1 to 2%. Low, that's great, but it's also important to appreciate this means that endoscopically we can't cure at least 1 to 2% of these patients. And I think it's very important that both physicians and patients appreciate this. There is a risk that you will miss these patients with metastases. Now, esophagectomy does have the potential to cure patients with lymph node metastases. And actually, before conducting this systematic review, I thought that perhaps young patients with high-grade dysplasia in Barrett's probably should have an esophagectomy rather than endoscopic treatment. But in fact, performing this review changed my mind, and I now feel that the risk of lymph node metastases alone does not warrant the choice of esophagectomy over endoscopic therapy. Why? Because esophagectomy in most centers has a mortality rate around 2%, much higher in some centers, but that's a rate that exceeds the rate of lymph node metastases. That means that more patients will die from the operation than would have died from metastatic disease. And esophagectomy has the additional problem of some substantial morbidity, and there's certainly no guarantee that esophagectomy is going to cure a tumor that already has metastasized to regional lymph nodes. There might be distant metastases as well. Anyway, all of this means that accurate T-staging is absolutely crucial if you're going to determine if curative endoscopic therapy is feasible. For patients with high-grade dysplasia and intramucosal cancer, whose risk of lymph node metastases is only 1 to 2%, curative endoscopic therapy is feasible. But if there's submucosal invasion, then the risk of lymph node metastases exceeds 10%, and most endoscopists would consider that too high a risk and that therefore unacceptable. So accurate T-staging is crucial, and endoscopic mucosal resection, or EMR, is the best procedure that we have for T-staging these early cancers in Barrett's esophagus. Now, initially, we used EMR as a therapeutic procedure to resect neoplasms in Barrett's. But today, EMR is at least as much a staging procedure as it is a therapeutic procedure. If the EMR specimen shows us that there's submucosal invasion, then endoscopic therapy is advised. And this brings us to ablation. Now, presently, the preferred ablation technique is radiofrequency ablation. This uses a generator to deliver radiofrequency energy. That's just microwaves, radiofrequency, and it delivers it to the esophagus through this balloon-based arrangement of closely spaced electrodes. Here's a cartoon of the inflated RFA balloon positioned in the esophagus, and this is what it looks like when you push the button and you ablate it. In 2009, Nick Shaheen and his colleagues published the results of a randomized, sham-controlled trial of radiofrequency ablation for dysplasia. 64 patients with low grade and 63 with high grade were randomized in a 2-to-1 fashion to get either real ablation or a sham ablation procedure. Intention to treat analysis showed that 81% of patients with high-grade dysplasia who had ablation had no dysplasia detectable at 1 year, compared to 19% in the sham group. And for low-grade dysplasia, 91% had no dysplasia at 1 year, compared to 23% in the sham. Radiofrequency ablation also prevented the progression of neoplasia. Only 3.6% of the ablated patients progressed to a higher grade of neoplasia by 1 year, compared to 16.3% in the sham group, and only 1.2% of the ablated patients progressed to cancer, compared to 9.3% of the sham group. Complications included 5 strictures, 1 minor upper GI bleed, and 2 hospitalizations for chest pain. Now, that is by no means a trivial rate of complication, but it's far less than what's been reported for alternative treatments like photodynamic therapy or esophagectomy. Now, it's important to appreciate that there's a high rate of metachronous neoplasms after endoscopic therapy of Barrett's neoplasia. In this study from the Wiesbaden group in Germany, who has perhaps the most extensive experience in the world, 349 patients who had mucosal neoplasms in Barrett's. The investigators performed endoscopic therapy with endoscopic mucosal resection or photodynamic therapy that was focused on the neoplasm. Now, sometimes these patients had the Barrett's ablated, okay, the Barrett's around the neoplasm, and sometimes they didn't ablate the Barrett's, all the remaining Barrett's. They just took out the neoplasm. 337 patients had a complete response where everything seemed to be gone, the neoplasia was eradicated, but during a mean follow-up of 64 months, 22% of those patients were found to have metachronous neoplasms. Now, when they looked at who got metachronous neoplasms, they found that 17% of the 200 patients who had their Barrett's epithelium ablated after the primary neoplasm was removed developed the neoplasm, but almost twice as many, 30%, developed in the patients whose Barrett's was not ablated. So based on these data, in 2013, endoscopic therapy for mucosal neoplasms in Barrett's starts with endoscopic mucosal resection of any visible mucosal irregularities. That EMR provides you with crucial staging information, and the EMR can be therapeutic as well. And based on that data that I showed you and a little bit more, it appears that you should ablate the remaining Barrett's metaplasia with RFA to minimize the development of metachronous neoplasms. Now, before we end, I'd just like you to consider an interesting proposal that routine polypectomy for colon polyps and RFA for non-dysplastic Barrett's are intellectually the same. Now, understand that before colonoscopy became widely available in the 1970s, if we found a small colon polyp on a barium enema, we wouldn't immediately send that patient for surgery to remove the polyp. That's because we knew that most small polyps would never become cancer, and because before colonoscopy, the only way to get rid of that small polyp was to have a big operation. Well, these authors, Hashim El-Sarraj and David Graham, make the case that non-dysplastic Barrett's esophagus is like having a small colon polyp. Most colon polyps don't become cancerous. Most Barrett's esophagus doesn't become cancerous. But now that we have colonoscopy, we take out all of the colon polyps that we find, regardless of their size, because we don't know which ones will eventually turn into a cancer. And with colonoscopy, we have a safe and easy way to remove the polyps. Well, these authors argue that radiofrequency ablation, like colonoscopy, is safe and effective, and therefore, our current practice of limiting RFA only to Barrett's with dysplasia would be like limiting polypectomy only for polyps that are clearly large and clearly malignant. And if you follow this logic, then shouldn't we recommend that all of our patients with Barrett's, dysplastic or not, shouldn't they all have radiofrequency ablation? Well, I think it's an interesting argument, but we have a couple of issues to resolve before we accept this. One of the unresolved issues that we have to deal with relates to the frequency and importance of buried metaplastic glands, which is also called subsquamous intestinal metaplasia. If we do an ablation procedure and it destroys all of the Barrett's metaplasia, then the partially ablated mucosa might heal with an overlying layer of neosquamous epithelium. Neo just means new, so new squamous epithelium that buries metaplastic glands in the lamina propria. Now, they're hidden there from the endoscopist. The endoscopist can't see them. And there are reports of cancers developing in these buried glands after RFA for Barrett's esophagus. And look at the results of this report on three-dimensional optical coherence tomography for identifying buried glands. Now, this is a microscopic imaging technique. It reaches a depth of up to 2 millimeters, and it samples an area some 60 times larger than a biopsy forceps. This shows OCT images of that EMR specimen that you see in the right panel, and the red arrowheads show you where the buried glands are. Well, in 18 patients who had this procedure at the squamocolumnar junction, 72% had buried glands. This is before complete eradication of the Barrett's. After eradication, 63% still had buried glands. And they concluded that buried glands are present at the squamocolumnar junction in most patients, both before and after RFA. So the importance of these buried glands remains unclear. It's also not clear how durable is the response to RFA. Now, this is a study reported earlier this year. It's a retrospective cohort study of 112 patients with dysplasia who had their intestinal metaplasia completely eradicated by RFA. Now, to get rid of all that Barrett's took 3 RFA sessions, a mean of 3 sessions. So don't think of this as a one-time procedure. It's not just one. It required 3 procedures to get rid of all the Barrett's. And the patients were followed for a median of 397 days. And during that time, 8 patients developed recurrence. In 3 cases, it was non-dysplastic. 1 recurrence was with low-grade, 1 with high-grade dysplasia. 1 patient who started with high-grade dysplasia had a recurrence with cancer, and 2 patients progressed to adenocarcinoma. 1 died of metastases. And this is what the Kaplan-Meier plot of that intestinal metaplasia recurrence looked like. So in this study, which is actually one of the more conservative ones, intestinal metaplasia recurred at a rate of 5.2% per year, and much higher rates have been reported in other studies. And dysplasia progression occurred at almost 2% per year, and clearly that's not a permanent eradication in a substantial proportion. So there are many questions about RFA that have to be resolved before we can recommend it to treat the millions of patients out there with non-dysplastic Barrett's. If you want to recommend RFA for non-dysplastic Barrett's, recognize that it generally requires several procedures to achieve complete eradication. It has a complication rate that is low but not trivial, probably about a 5% risk of esophageal stricture development. Recognize that the durability of the procedure is not clear, that the frequency and importance of buried glands are not clear, and that the efficacy of RFA in reducing the already low rate of cancer development in non-dysplastic Barrett's is not established. And after the procedure, these patients almost certainly will require some kind of endoscopic surveillance, so you don't get rid of that problem either. For all these reasons, the AGA says that endoscopic eradication therapy is not suggested for the general population of patients with Barrett's esophagus in the absence of dysplasia. But they put a little proviso in here by stating that RFA should be a therapeutic option for select individuals with non-dysplastic Barrett's who are judged to be at increased risk for progression to high-grade dysplasia or cancer. But in what I think is really the ultimate hedge, they conclude that specific criteria that identify this population have not been defined. Now, to interpret guidelines like these require both knowledge and wisdom. And for anyone who doesn't know the difference, knowledge is to know that a tomato is a fruit, not a vegetable. Wisdom is to know that you don't put a tomato in a fruit salad. Thank you very much for your attention.